Hey everyone, I am Dr. Sashikant and I am going to discuss today regarding the FMG January 2026 recall PYQs. So let's dive into that. So 40-year-old woman presents with headache, there is a headache and undergoes evaluation for brain tumor and there is a CP angle tumor. So CP angle tumor is there. Histopathological examination shows the tumor composed of Antony A area, Antony B area. Which of the following is the most sensitive immunohistochemical marker? So this is the question. So here important thing is that S100 is one of the important marker, neurological marker that is commonly noted. So S100 may be a probable answer. Let's figure out S100. It is commonly seen in neural tumor, Schwann cell tumor. It also stains sustentacular cell as well. So S100 is positive in schwannomas, neurofibromas. So this is a classical description of schwannomas. So this is likely to be the correct answer, but let's rule out the other option as well. GFA is more characteristic of astrocytic tumor, astrocytic tumor, and EMA is characteristic of CNS tumors like meningioma. Apart from that, it may be also present in many of the epithelial tumors elsewhere. CKIT is characteristic of GIST, seminoma, dysgerminoma, and some other tumors, but it is generally not seen, not a part of schwannoma or neurofibroma. So here it is schwannoma. How do you identify it? Antony A area, which is quite cellular and having Verroque bodies, and Antony B areas, which is myxoid and loosely cellular area. So the diagnosis is schwannoma, and the correct answer will be S100 protein. That is the correct answer. Let's go to the another question. Burkitt's lymphoma is associated with Epstein-Barr virus, which is the primary mechanism involved. So here, these are the important. These are the options: activation of BCL2 causing inhibition of apoptosis. So this is the wrong option because this is the option for follicular lymphoma. But here it is Burkitt's lymphoma, BCL2 activation and inhibition of apoptosis, because BCL2 is an anti-apoptotic gene. So this will cause inhibition of apoptosis, prolongation of survival of the cell life. So that is the case in follicular lymphoma. EBV mediated c-MYC activation, yes, this could be one of the correct answers. This is in fact the correct answer. c-MYC activation, EBV, there is a LMP1 protein, latent membrane protein 1, and that causes the oncogene c-MYC oncogene activation. And EBV integration causing P53 gene deletion, the third option is incorrect. This is not the prime mechanism over here. Overexpression of cyclin D1 due to T1114, this is speaking about mantle cell lymphoma. And also important thing to note that apart from there is a c-MYC, there is n-MYC. N-MYC is characteristic for neuroblastoma. So important thing, c-MYC for Burkitt's lymphoma, n-MYC for neuroblastoma, N for neuro. So you can easily remember that n-MYC stands for neuroblastoma. So the answer here what we derived is c-MYC. The B option is correct. EBV mediated c-MYC activation and EBV integration causing P53 gene deletion. This is not the prime mechanism. This is the correct answer. So now let's go to other option, other MCQ. The next MCQ: which genetic abnormality is associated with Burkitt's lymphoma? Another MCQ on Burkitt's lymphoma. So you see that Burkitt's lymphoma is a very high topic. So let's see what are the options. The options are 1418 translocation, 1114 translocation, there is 814 translocation, 922 translocation. So here important thing is 1418 translocation. Let's talk about this. This is a characteristic feature of follicular lymphoma. And here BCL2 As we discussed in the previous question, BCL2 is overexpressed. This 1418 translocation leads to BCL2 overexpression, and that leads to follicular lymphoma. So in follicular lymphoma, important point is that and it is untreatable, unmanageable, though it has an indolent course, but the response to chemotherapy may be poor because it is having increased lifespan of the cells. So it's not a true neoplastic proliferation of the cells, it is prolongation of the lifespan of the cells because of increased BCL2 expression. So though it is a low grade lymphoma, but shows poor response to chemotherapy because of that. Now coming to the other one, 1114. So here the cyclin D overexpression takes place, and it is talking about mantle cell lymphoma, another low grade B cell lymphoma, which can be present in internal organs and lymph node. So this is not the case over here. 814 translocation, yes, this is the characteristic feature. 814 translocation of Burkitt's lymphoma that leads to c-MYC overexpression. So Burkitt's lymphoma, remember that it could be this is a various type. There is endemic type, there is AIDS associated type, there is a transplantation associated type. There are different variants, there are sporadic variants as well. So Epstein-Barr virus associated and is very common with the endemic one, and often in Burkitt's lymphoma you will see the jawbone enlargement and abdominal mass can be seen. And Burkitt's lymphoma also, you need to remember starry sky appearance, often asked in MCQ, starry sky appearance. That is lots of homogeneous cell proliferation, and among the homogeneous dark B cell proliferation there are lighter macrophages. So that is called as the starry sky macrophages, starry sky appearance. And there are tingible body macrophages with macrophages ingesting the tumor cells. So that is the starry sky appearance. And c-MYC 814 translocation, this is the correct answer. And here this is a very high grade lesion, but response to chemotherapy is good if treated at the early stage. So that is about Burkitt's lymphoma. 922 translocation, this is speaking about Philadelphia chromosome. Philadelphia chromosome is positive in CML, mostly almost 95% of the CML, and it is also present in some cases of ALL as well. If it is present in ALL, it portrays a poor prognosis. That is a common type of question to be asked. So ALL prognostic markers are very important. CML, 95% cases are having 922 Philadelphia chromosome. 5% cases they are negative for Philadelphia chromosome, but still BCR ABL is positive in all of the cases, all 100% of the cases. And this 5% of the cases which are negative for Philadelphia but still positive for BCR ABL, this is called as atypical CML. So these are some important points you need to know, and the answer here is the typical 814 translocation that is characteristic of Burkitt's lymphoma. So the answer here is Burkitt's lymphoma. Answer here is Burkitt's lymphoma 814 translocation, option 3. That is the correct answer. Now let's go to another option, another MCQ. Let's go to the next MCQ. Peripheral blood smear is given blast count for more than 60%. So very high blast count. This is, I'll just note it down. And there is immunophenotyping that reveals positivity for CD13 and CD33, negative for CD19. So CD19, what it is? It is a B cell marker. It is one of the pan B cell marker. So B cell lymphocyte marker is not there. So this is ALL is ruled out. And CD13 33 is positive. So CD13 33 are all myeloid marker. And here you can see even some OR rods, some elongated rod like structures. You can see some OR rods or some fagots. A bundle of OR rods are also noted over here. So elongated rod like structure, these are characteristic of myeloblast. So these are myeloblast. So here what is the diagnosis? So CML is not CML can be the answer, but why it is not the answer over here? Though there are myeloid marker is positive over here, though it can have myeloblast, but the blast count is 60%. So as per the WHO definition, blast count is more than 20% in the peripheral blood and or bone marrow. It qualifies for AML. That is the thing over here. So if it is more than 20%, it should qualify for acute myeloid leukemia rather than chronic myeloid leukemia. Now chronic myeloid leukemia has different phases, like chronic phases, accelerated phases, blast phases. So chronic and accelerated phases. Chronic phase of CML blast count is generally less than 5% or 10%, and accelerated phase between 10 to 19%, and if it is more than 20 or more than 20, it is blastic phase, but nothing but a conversion of CML to AML, or sometimes even CML can convert to ALL as well. But here coming to the question, the answer is AML because of 60% blast, 1333 positivity or rod positivity negative for CD19. CLL is a B cell tumor, so B cell markers are negative, and 1333 are not the markers of lymphoid cells. So CLL is also ruled out, and CLL you will also not see so much blast cells. So CLL, ALL, and even CML is also ruled out. So the correct answer will be AML. Remember the AML, more than 20% blast cells and 1333 positivity, or rod is positive over here. These are the characteristic marker. So the answer here is AML. Now let's go to the next question. A 6-year-old child presents with joint pain. So joint pain is the option, is the one of the vignette. Purpuric rashes, you can see lots of purpuric rashes, spots, hemorrhagic spots all over the extremities, and the rash is palpable, non-blanching. Image of the rash is shown. Child complains of colicky abdominal pain. Another vignette. So what is the most likely diagnosis? So the diagnosis here is let's see the options, then we will derive the answer. Immune thrombocytopenic purpura, acute rheumatic fever, Kawasaki disease, Hinox-Conlin purpura. So these options are noted. Now let's rule out options one by one and derive the correct answer. ITP will present with this rashes and all, but colicky abdominal pain and joint pain, these are generally not the feature of ITP. So ITP is ruled out. ITP, how it starts? It starts with some respiratory infection, generally upper respiratory tract infection. There is immune mediated destruction of the platelets, and the characteristic feature in the bone marrow is increased megakaryocyte. So those are some identifying features. You must be very careful regarding that to identify them. Acute rheumatic fever will not have this kind of a rashes. There may be some rashes, but overall this kind of a typical purpuric hemorrhagic rashes all over is not the feature of acute rheumatic fever. So there may be some erythematous rashes, but small purpuric spots everywhere will not be a feature of acute rheumatic fever. Kawasaki disease is again a childhood vasculitis. It is a childhood vasculitis. It can have some erythematous rashes, but the characteristic feature more is of lymphadenopathy. There is a strawberry tongue that is seen in Kawasaki disease, and generally it involves the medium-sized blood vessels. Coronary artery involvement is characteristic. It has lots of other complicated desquamative lesions as well, and this kind of a purpuric rashes are not the typical feature of Kawasaki disease, so ruled out. So everything is ruled out. Acute rheumatic fever is ruled out. Immune thrombocytopenic purpura is ruled out. Kawasaki disease is ruled out. Now let's talk about henox-cannulae purpura. So this is the correct answer. Why it is the correct answer? Because HSP, what happens here? IgA deposit in the blood vessel across the body, around, it circulates and gets deposited in the blood vessels. It is multisystemic, and also involving it is also involving the skin, abdomen, blood vessels, and even the blood vessels of the kidney as well is also involved. So in kidney it produces mesangial proliferative glomerulonephritis, and rest all everywhere in the blood vessel it gets deposited. It makes the blood vessel wall fragile, and it is susceptible to bleed. So that will cause purpuric rashes, and generally it involves the abdomen and joints as well. So arthralgia, abdominal pain, purpuric rashes, three classical clinical features of HSP or henox-cannulae purpura. So abdominal pain, joint pain, arthralgia, purpuric rashes. These are all characteristic features of HSP. And remember, very commonly asked, IgA type of one, and in kidney it causes mesangial-proliferative glomerulonephritis, just like that of a Bridger's disease, which is an isolated IgA nephropathy, and IgA nephropathy can also be seen in association with that of HSP as well. So the correct answer is henox-cannulae purpura. This is the right answer. Now let's go to the next question. Which of the following is most commonly used immunohistochemical marker for neuroendocrine tumors? So this is a very classical question. You must remember some common neuroendocrine markers, common immunohistochemical markers for various common tumors that is being repeatedly asked in your FMGE exams. So let's talk about the various options. Chromogranin. Why chromogranin? Chromogranin is one of the commonest marker of neuroendocrine tumors. What are the neuroendocrine tumors? Having neuroendocrine granules in them. Electron microscopy also can confirm them. They are generally having the cells are having small granules, stippled chromatin pattern. And what are the neuroendocrine tumors? Common examples: small cell carcinoma, carcinoid tumor, sometimes even large cell tumors of lung that can also show neuroendocrine features. Apart from that, many other tumors also have neuroendocrine features, and there can be even like paraganglioma. The two most common one are small cell carcinoma and the carcinoid tumor. There are other lesions as well which may have some of the cancers even show neuroendocrine property. So important markers you need to remember: synaptophysin, chromogranin. These are the two most specific markers. Sometimes NSC, neuron specific analysis, and rarely S100 may also be positive, but S100 is more positive in the neurogenic cells, the Schwann cells originating tumor, that is the neurofibroma, neurolemoma, and some sustentacular cells. But generally it does not decorate, it does not stain the neuroendocrine cell. So S100 is ruled out. And P63, it is a basal cell marker, basically a basement membrane marker, basement membrane marker or basal marker, and also it is a squamous cell marker, helps to identify the squamous differentiation as well. So it is a squamous marker as well. So this is not the case. It is ruled out. Now nepsin A may be present in some of the cancers like adenocarcinomas and all. It may be positive, but it is not the marker for neuroendocrine cells. So the neuroendocrine cells positive markers are synaptophysin and chromogranin. So out of these, here the chromogranin is the option. So option 1 is the correct answer. So you must remember the common immunohistochemical marker of different tumors which are repeatedly being asked as MCQs. You need to identify them, either directly asked as is seen in this question, or it may be in the form of some of the vignettes where it can be asked. So the correct answer here is chromogranin. So now let's move to other question. Next question. A 19-year-old boy presents with long limbs and hypermobility. So classical vignette, long limbs and hypermobility in the joints. Genetic analysis, mutation in FBN1 gene. So most likely diagnosis. So let's rule out, let's go to the correct diagnosis and rule out the other wrong options. Marfan syndrome. Is this the correct answer? Yes, this is the correct answer. And why? Because in Marfan syndrome, fibrillin 1 is defective and fibrillin 1 is encoded by FBN1 gene. So what happens in Marfan syndrome? There is high risk of aortic dissection, aortic aneurysm, there is lens subluxation, there is also there are also hyperextensible joint can be seen, hypermobility of the joint can be noted, and there can be the skin is also a little bit fragile, cardiovascular complications and elongated long extremities. These are the classical features of Marfan syndrome. So these are the most important feature of Marfan syndrome. And here important thing to note that uh, it has to be differentiated from Ehlers-Danlos syndrome. So Ehlers-Danlos syndromes must be differentiated. Why? Because Ehlers-Danlos syndrome is also likely to have hypermobility, and most important is hyperstretchability, like more stretchable joints, super elastic joints. So super elastic joints and elastic like you can stretch it and then release it, it will come to its it is hyper stretchable. The skin is also hyper stretchable and hyper extensible. This is more likely to be Ehlers-Danlos syndrome, but Ehlers-Danlos syndrome FBN gene defect is not there, multiple collagen defects are there, of different collagen defects are there. So rather than the fibrillin, the basic defect is collagen defect, and it is of cardiovascular, skeletal, different types of Ehlers-Danlos syndrome. 8 to 9 variants exist with different kind of a predominant clinical feature. So this will be ruled out over here, as FBN1 is not the defect over here. Homocystinuria. Homocystinuria means homocysteine to cystathione conversion is lacking over here. So cystathione synthetase is lacking over here. So that means more of homocystinemia and associated homocystinuria. So here also Marfanoid habitus can be present. So Marfan-like feature can be present over here in homocystinuria as well. But here the FBN gene defect is not there. The enzyme cystathione synthetase is defective over here. So this is also ruled out. Apart from that, homocystinuria can be seen in some of the associated with the vitamin B12 and folic acid deficiency as well, because they are the coenzymes in those metabolic reactions. So in those deficiency also you may get some kind of a homocystinemia and homocystinuria, and it predisposes to arterial thrombosis. It is an independent risk factor for increased atherosclerosis risk. So this is not the case over here. There is no FBN gene defect, so it is ruled out. Now coming to another rare type of condition, Loeys Dice syndrome. So here there is a TGF beta defect. TGF beta defect. And it also leads to Marfanoid features, and also it leads to early childhood aortic dissection and aortic aneurysm. And apart from that, there is some uvula defect, and apart from that there is hypertelorism, that is also a feature of Loeys Dice syndrome. So this is ruled out. There is no FBN gene defect over here, TGF beta defect, that leads to Marfanoid like feature, but more predominant features of uh, cardiovascular abnormality. So the genetic defect is different. So here we will go with the diagnosis of the classical Marfan syndrome. Next, 22-year-old male presents with anemia. So anemia is classical. Peripheral smear is given and reticulocyte count is 6%. What is the most likely diagnosis? It is asking what is the most likely diagnosis. So these are the options. So here you can see in the image, the cells are exceedingly small, and here you can see some target cells. How does the target cells look like? Hemoglobinization in the center, then a rim of pallor, and the periphery also there is some kind of a hemoglobinization. So dual hemoglobinization and a rim of pallor. So this is target cell. These are seen over here. Apart from that, you are also seeing some kind of a sickle cell. So how does the sickle cell look like? Crescent shaped. So these are the sickle cell. You can see that they are in abundance. The sickle cells are generally obvious when there is homozygous sickling. In heterozygous sickle cell disease, it will not be obvious, but in homozygous state, generally they are obvious in the peripheral smear. The morphological features are obvious. So here reticulocyte count is 6%. What does it imply? In all hemolytic anemias, reticulocyte count is high because reticulocyte count denotes the proliferative ability of the bone marrow. So hemolysis, more of reticulocyte count will be there because the bone marrow will try to compensate that by producing more of reticulocyte. So reticulocyte count, retic count goes high. So that is the classical case of all the hemolytic anemias. Retic count is high, LDH is high, there is high risk of gallstone formation, pigmented gallstone formation. These vignettes are common to all hemolytic anemias. This is not very specific, but what is the most specific thing over here? Identifying the sickle cells in the image. So it is sickle cell disease or sickle cell anemia. Let's rule out other options, as the answer is very obvious here, sickle cell disease, but we must know how to rule out the option. Iron deficiency anemia will not have target cells, and generally target cells, even if they are there, they are few in number, and you will see more of microcytosis, no sickle cell, and there will be it can be additionally confirmed by doing iron studies. There may be concomitant iron deficiency anemia in sickling as well, but that is not the prime etiology over here. The etiology here is of the anemia is the sickling, and that is causing severe hemolysis, and hemoglobin count in sickling may be even in the crisis it may go down to as low as even 3 to 4 gram percentage. So here iron deficiency anemia is not the prime cause over here. And iron deficiency anemia, many a time you get elongated pencil cells which are not being seen over here. So this is iron deficiency anemia. Confirmation by doing iron study indices, that is most and very commonly asked which is the most sensitive marker for iron deficiency anemia, that is ferritin. So always go for the ferritin as the option. So here iron deficiency anemia is not the cause. Iron deficiency anemia is ruled out. Thalassemia trait, very commonly confused with that of iron deficiency anemia, very strong mimicker of thalassemia, iron deficiency anemia. Hemoglobin is generally 10 to 12, generally asymptomatic. Mild anemia, microcytic hypochromic anemia is seen, and thalassemia trait is should have the hemoglobin A2, HbA2 more than 3.5 percentage. That should be the minimum HbA2 level in thalassemia trait, beta thalassemia trait, and microcytic hypochromic anemia is seen. So this is not the case over here. There is no sickle cell over here, so this is also ruled out. How to differentiate between iron deficiency anemia and thalassemia trait? IDA, iron deficiency anemia, RDW is very high, red cell distribution width is very high in iron deficiency anemia, whereas in beta thalassemia trait you will see that beta trait, you will see that the RDW is low. RDW is normal to low. So this is not the case over here, and here the diagnosis is not thalassemia trait, so we will rule it out. Now coming to aplastic anemia. How does aplastic anemia happen? What does aplastic anemia cause? Aplastic anemia refer to bone marrow suppression, and there is decreased RBC, WBC, and platelets associated with that. So decrease RBC, WBC, and platelet are associated. There is no sickle cell associated with aplastic anemia. So aplastic anemia is also ruled out, and because aplastic anemia will not have this sickle cell, there will be decreased RBC, WBC, and platelets. All series will be decreased, and there will not be any sickle cell. Commonly, it is an indication of bone marrow failure, and in aplastic anemia, you will see that the bone marrow is quite hypoplastic, and there is more of fat element. The cellularity is much lower as per the compared to the reference age. Compared to the reference age, there will be much reduced cellularity of the bone marrow. So that is ruled out. So the correct answer here is sickle cell disease. What are the favors? What are the points in favoring of sickle cell disease? Reticulocytosis, hemolytic anemia, and there is sickle cell directly demonstrated in the peripheral blood. So here it is typically a sickle cell anemia. Now let's go to other option. Patient has parathyroid hyperplasia and pancreatic neuroendocrinal tumor is there, and recurrent peptic ulcer. So these are the important features of that. And here now let's see what is the answer. So it is asking which is the common mutation, which mutation is seen in this particular condition. So the common mutation associated, what is the diagnosis first that we need to identify? So the diagnosis, the common diagnosis that is seen over here is MEN1 syndrome. Remember, MEN1 syndrome and MEN2 syndrome are very important, always being asked. So MEN1 syndrome, MEN2 is again MEN2A and MEN2B. MEN1 syndrome is 3P, is also called as 3P syndrome. Commonly pituitary, pancreas, and parathyroid. Pituitary, pancreas, and parathyroid. Is involved in this MEN1 syndrome, whereas MEN2 syndrome, there is involvement of parathyroid, there is involvement of, there is medullary thyroid carcinoma, and also often there is pheochromocytoma. So these are seen in MEN2 syndrome, and MEN2B additionally may have some kind of a marfanoid feature, and mucosal neuroma may be noted in MEN2 syndrome. So but MEN2A and MEN2B both are associated with RIT oncogene mutation. RIT oncogene mutation are associated with MEN2 syndrome, but MEN1 syndrome, as is the case over here, there is a parathyroid tumor, pancreatic neuroendocrine tumor, and recurrent peptic ulcer. So what is the cause of recurrent peptic ulcer over here? So it is because of gastrine. Now this gastrine secreting tumor or gastrinoma is common in gastrinoma triangle, which is commonly seen over the duodenum and the pancreas. So the duodenum and the pancreas are the common areas where you will get the gastrinoma. And gastrinoma, it is also called as, the familial gastrinoma is also called as Zollinger-Ellison syndrome, ZE syndrome. So this is because of the gastrinoma or Zollinger-Ellison syndrome. This will cause multiple sites of ulceration. Important clue for examination: how to identify Zollinger-Ellison syndrome. Recurrent ulceration beyond the what is the common site of ulceration? That is, the common site of peptic ulcer is first part of duodenum, but if it goes beyond that, jejunum and other areas as well, so beyond the duodenal bulb, if it is going through, then it is called as then it is a typical feature of gastrinoma or Zollinger-Ellison syndrome. Normally with H. pylori there is duodenal ulceration, but with Zollinger-Ellison syndrome, multiple recurrent ulceration is being noted. That is the correct answer over here. So MEN1, or which is encoded by menin gene, that gets abnormal over here. So this is the correct answer. Now let's RIT is basically MEN2 syndrome. This is MEN1 syndrome over here. Though there is a pituitary component is not being mentioned, but remember that you will not get all the components being mentioned in the vignette. Even in the classical clinical cases also, all the things may not be seen in the same patient as theoretically depicted. So here it is ruled out. TP53 is seen in many of the sporadically in many of the cancers, and it is also seen in Liefeld-Many syndrome. Liefeld-Many syndrome, in which multiple visceral cancers and some of the soft tissue cancers like osteosarcomas may be noted, and many of the visceral cancers are associated, like colon, pancreas, breast. Many of the cancers may be associated with inherited TP53 mutation, and it is also associated with many of the sporadic cancers as well. VHL gene mutation, this is von Hippel-Lindau syndrome. This is associated with VHL gene mutation. VHL gene mutation may also be associated with sporadic renal cell cancer as well. This is located on chromosome 3p, VHL gene. And commonly inherited syndrome is von Hippel-Lindau syndrome, in which you will see hemangioblastoma in the cerebellum and in the retina. There is a pheochromocytoma, there is renal cell carcinoma. In the sporadic renal cell carcinoma also, this VHL gene mutation will be seen. Commonly asked question regarding VHL on 3p, it is a tumor suppressor gene. It causes down regulation of, it causes check on hypoxia induced factor. Hypoxia induced factor 1, it causes a check on that. So in the absence of VHL functioning, this HIF will be upregulated, and that will cause cancerous changes. That will cause more of VEGF, vascular endothelial growth factor action, and it will cause more of cancerous changes, particularly renal cell carcinoma. It is closely associated with that. So the correct answer is in this is MEN1 or menin gene. Now going to the next question. Patient is diagnosed with a paroxysmal nocturnal hemoglobinuria. Which of the following drugs is used to reduce complement mediated hemolysis in PNH? Complement mediated hemolysis in PNH. What is the mechanism of PNH? CD55, CD59 defect. Increase complement mediated lysis is seen. Increased complement lysis is characteristic feature of PNH. So that is the thing. And why it is called as a PNH, commonly asked, because respiratory acidosis happens when during night time, when we sleep, there is decreased ventilation. We tend to take decrease, respiration is decreased, so more of carbon dioxide, respiratory acidosis. And respiratory acidosis due to any cause, whether it is respiratory or metabolic, it causes enhanced complement mediated action. So during the night time, there is more of hemolysis. The classical clinical vignette is that when the patient gets up early in the morning, is having cola color urine or darker urine, the characteristic feature of PNH. Now what are the drugs that is suitable in this scenario. Rituximab, let's go to each of them. Rituximab is anti-CD20, may be used in some of the lymphomas and all, so it is not the case over here, nothing to do with that. Eculizumab, eculizumab is C5 inhibitor, C5 inhibitor. So this will cause a check in accelerated complement mediated lysis that is happening over here. So this is the correct answer over here, eculizumab. Prednisolone steroid, it will not have a specific action on reducing, though it can cause reduced immune mediated destruction, but it is not as specific as that of eculizumab, because eculizumab will block the C5 complement and it will reduce the complement mediated lysis. Now what is hydroxyurea? Hydroxyurea is commonly used in conditions like sickle cell anemia and some of the other hemoglobinopathies as well. Its job is to increase the HbF synthesis. So particularly in case of sickle cell anemia, it will reduce the generation of HbS, and it will cause more of HbF synthesis. More of HbF synthesis, reduction of HbS will cause decrease sickling episodes and better compliance of the patient. So decrease HbS level, more of HbF, that is the job of hydroxyurea. This is being used for that purpose. So here the answer is eculizumab, a classical C5 antibody or inhibitor that will block the C5 action and causes decrease in the complement mediated destruction, which is a characteristic feature of PNH. So eculizumab is the correct answer over here. We'll go with eculizumab. Now let's go to other question. So important thing to remember in all PNH, hereditary spherocytosis, all these cases, there may be sometimes parvovirus infection which can lead to a plastic crisis. Apart from that, PNH is a condition which can predispose to, because the platelets are also broken down. So here in this case, there is high risk for platelet mediated destruction, and there is a more of platelet fragments are released, more of thromboxane A2 is released, that causes more of thrombogenicity. So lots of patients have hypercoagulability, Budd-Chiari syndrome, hepatic vein is particularly involved, some other veins also may be thrombosed. So hypercoagulability, more of thrombosis risk is higher in PNH patients. PNH patients are also associated with risk of transformation to acute myeloid leukemia or MDS even. So these are the features of PNH, and the correct answer in this case is eculizumab. So now let's go to the next question. So here patient presents with hepatosplenomegaly, crumpled tissue paper appearance. So here you can see the crumpled tissue paper appearance, hepatosplenomegaly is there. So here hepatosplenomegaly is a characteristic feature of Gaucher's disease, and apart from that, crumpled tissue paper appearance, the macrophages showing crumpled tissue paper appearance in bone marrow and in the reticuloendothelial cells. This is the classical feature of Gaucher's disease, and this is Gaucher cells. So this is the correct answer. Pom's disease, it involves more of heart and all. It is a cardiomegaly, so this is not the case. Niemann-Pick's disease, there is generally no hepatosplenomegaly. Tay-Sachs disease is also, you will not see this Gaucher cells, and you may see more of neurological manifestations, that cherry spots may be seen over the macula. So this Niemann-Pick's disease and Tay-Sachs are ruled out because there is no Gaucher cells. The crumpled tissue paper appearance is very characteristic of the Gaucher cells. The glucocerebrosidase deficiency is seen, and that leads to the accumulation of glucocerebroside, and that gives rise to this crumpled tissue appearance. So the correct answer here is Gaucher's disease. Now let's go to the next question. Patient with acute renal failure shows the collapse of capillary loops and parietal epithelial cell proliferation. So here there is collapse of the loop and parietal epithelial cell proliferation. It is saying. So what is the most likely structure? So parietal epithelial cells is classical of Bowman capsule. It is the outer layer of the Bowman capsule that gets proliferated. It is talking about, here you can see that it is talking about parietal epithelial cell proliferation, that is the characteristic feature of crescentic glomerulonephritis or RPGN, rapidly progressive glomerulonephritis, where you will see the proliferation of large proliferation of parietal cells of Bowman capsule, the outer layer of Bowman capsule. Apart from that, fibrin, macrophages, those are also the constituent of crescent. So crescent gets formed in the urinary space that blocks the urine outflow, and rapidly deteriorating kidney function is being noted. So here the structure here is Bowman capsule, and because the parietal cell is the layer of outer layer of Bowman capsule, and the inner layer is called as the visceral layer, the innermost layer, inner layer of the Bowman capsule that is basically the outer layer of the glomerular capillaries. That is the visceral layer. Parietal layer and visceral layer both are part of Bowman capsule. So Bowman capsule is the correct answer. Mesangial cells are present between the glomerular capillaries. They are present over here, and this is composed of some mesangial stromal cells and the connective tissue matrix. So these are just like pericytes or stromal cells which have different functions. Mesangial cells have different functions, like they provide support to the capillary architecture, and they are also having phagocytic action. Apart from that, they secrete various substances also. So mesangial cell is not the case over here. They are not involved in the crescent formation. Islet cells, it is feature of pancreas, and here you have alpha, beta, gamma, delta cell, and as you know that beta cell secretes insulin, alpha cell secretes glucagon. So that are islet cells. So this is not the case over here. It is islet cell are not a part of kidney. Leydig cells are the testosterone secreting cells. So you can remember it as LT, or abbreviated from lecture theatre, something you can call it as. And LT, basically Leydig cells, these are present between the seminiferous tubules. They are rounded cells. They secrete testosterone. They are largely responsible for the secretion of testosterone. So they are the Leydig cells, and this is not present over there in the kidney. So that is also ruled out. So Leydig cell ruled out, mesangial cell ruled out, islet cell ruled out. Correct answer will be Bowman capsule. So that is the correct answer. Next question, 65-year-old male, history of smoking, presence with chronic cough and shortness of breath. Bronchoscopy reveals influx of neutrophils and macrophages. So neutrophils and macrophages are there in his airways. Which of the following enzyme breakdown will be responsible for these condition? So here it is talking about chronic cough, shortness of breath. Bronchoscopy reveals neutrophils and macrophages. Which of the enzyme breakdown will be responsible for his condition? So in all the chronic bronchitis and other conditions, COPDs basically, there is large influx, or there is large accumulation of neutrophils and macrophages in the airways. And what does this neutrophil and macrophage have? They have large amount of proteases. Proteases causes destruction of many of the fibers, that it can cause destroy the collagen, elastin, and many other substances as well. So in airways, elastic fibers is the predominant constituent, and in cases of emphysema, like conditions like centri acinar emphysema, which is associated with smoking, there is shortness of breath is seen over that condition as well. Here you will see that elastic fibers are broken down because of excessive release of elastase by the neutrophils and macrophages because of the smoke inhalants. So that causes more accumulation of neutrophils and macrophages in the airways, which destroys the elastic fibers, and it causes a large amalgamation or fusion of the airways. So large dilated airways or emphysematous airways. It is characteristic of centriacinar emphysema. So elastase is the major thing that gets destroyed in the smokers. So elastase is elaborated by neutrophils and macrophage, and this will break down elastin. Elastin is the fiber and elastase is the enzyme. Enzyme will cause the breakdown of elastin. So elastase is the correct answer over here, which will break down the elastic fibers, or elastin is the protein. So that will the correct answer here is elastase. Elastase is the enzyme or the proteases which are elaborated by the neutrophils and the macrophages. Collagenases will degrade the collagen, but here it is in the airways. The most important feature that is responsible for the symptom is elastases, not the collagenases. So here it is the correct answer is elastase. Peroxidase is basically referring to myeloperoxidase, which is present in the neutrophils and all, but as such it does not have any implication in the airways. It is inherently present in the granules of neutrophils. So that is there in the MPO, and in many of the myeloid leukemias, this MPO staining is used to decorate those granules. Anti-MPO can be also used to stain the myeloperoxidase. So this is basically a characteristic of myeloid cells or the neutrophils, or basically it is used for that purpose. It is not implicated in the damage to the airways. So the correct answer is elastase. So we will go with the answer elastase. Everything else is ruled out. Going to the next question. 45-year-old female presents with rapidly enlarging mass raising from the uterine wall along with the perimenopausal bleeding. So there is a perimenopausal bleeding. Histopathological examination is suggestive of malignant smooth muscle tumor, which is the most likely diagnosis. So here you can see this, there are cells which are looking atypical. Atypical cells are being seen over here. So this atypical large cells are characteristic features, and there is a smooth muscle tumor from uterine wall. So this is uterine wall atypical cells. This could be leiomyosarcoma, or sometimes even cellular leiomyoma has some atypicality and some kind of a increased mitosis can also be seen over there. But the most important feature here that is saying is suggestive of malignant smooth muscle, because there is so much of atypia, and so this the malignant part of the leiomyoma, the counterpart is called as leiomyosarcoma. That is the correct answer over here. How to differentiate leiomyoma from the leiomyosarcoma? That is a classical thing to be asked. So the most common thing that differentiates leiomyoma from leiomyosarcoma is that of coagulative necrosis, atypia, and number of mitosis 10 per 10 hyper field, 10 per 10 HPF, more than 10 mitosis per 10 HPF. Coagulative necrosis, any small foci of coagulative necrosis is a strong indicator of leiomyosarcoma, and atypia and mitosis are also equally important, but the most important indicator is coagulative necrosis. So here atypia is seen, not able to demonstrate coagulative necrosis and mitosis over here, but atypia is markedly noted. Elongated cells with hyperchromatic nuclei and variable, there is nuclear pleomorphism as well. So this is a characteristic feature of leiomyosarcoma. So we will go with the diagnosis of leiomyosarcoma. Leiomyoma can be there, but here as it is suggestive of malignant transformation, atypia is there, so this is ruled out. Endometrial, this is basically a smooth muscle tumor, and endometrial carcinoma is not a smooth muscle tumor, it is derived from endometrial tissue. So by definition, it is ruled out. What is adenomyosis? This is also ruled out because adenomyosis means expansion of the endometrium into the myometrium. Endometrial glands and stroma are confined to the are also extending beyond the endometrial boundary, and it is also infiltrating the the myometrium as well, resulting in globular enlargement of the uterus. That is a characteristic feature of adenomyosis. Diffuse rounded enlargement of the uterus, that is the classical feature of adenomyosis. Also presents with dysmenorrhea, menorrhagia, and it is differentiated from endometriosis. Adenomyosis, how to differentiate from endometriosis? Adenomyosis is only confined, the endometrial glands and stroma are confined to the myometrium only, whereas endometriosis beyond the myometrium, if it is going, then it is called as endometriosis. Like if it is going to cervix or if it is going to ovary, then it is endometriosis, then it is not adenomyosis. So the correct answer here is leiomyosarcoma. This is the correct answer. Going to the next question. Patient presents with a pallor, fatigue and glossitis, peripheral smear given below. So which is the most likely diagnosis? So here you can see hypersegmented, almost 10 to 12 lobes are seen over here of the neutrophil, and macrovalocytes, some large macrocytes, occasional macrocytes are seen, but the classical hypersegmented neutrophil is a classical feature. This is the early sign. Here the macrovalocytes are not very conspicuous, but hypersegmented neutrophils are the early feature of megaloblastic anemia. Megaloblastic anemia, either B12 or folic acid. So as there is no folic acid over here, as there is no B12 being given over here, so we will go with the folate related megaloblastic anemia. That is the correct answer. Iron deficiency anemia will not present with hypersegmented neutrophil. Also pallor, fatigue, glossitis, these are all characteristic feature of megaloblastic anemia. So either B12 or folate. The difference between B12 folate is that of neurological manifestation. In folate, in B12 you will see some neurological manifestation, degeneration of spinal columns, posterior columns will be seen, proprioception and vibration sensation will be impaired. So that is not being mentioned over here, and B12 is not there in the option, so folate is the correct answer. Aplastic and iron deficiency anemia, you will not have these features, pallor, this glossitis feature, and you will not have the hypersegmented neutrophils as well. Though aplastic anemia may have macrovalocytes, but hypersegmented neutrophils may not be seen over there. So here it is the classical megaloblastic anemia due to the folic acid deficiency. Thalassemia major also you will not see the glossitis feature, and apart from that, thalassemia major, you will see lots of hemolysis, you will see lots of target cells, and you will see also lots of nucleated RBCs. Those will be quite conspicuous in thalassemia major. So this is ruled out, this is ruled out, this is ruled out. So the correct answer here is folate related megaloblastic anemia. Iron deficiency anemia, aplastic anemia, thalassemia major will not have hypersegmented neutrophils and will not have glossitis also. The most important thing is hypersegmented neutrophil over here, and some of the macrovalocytes are there. So that is characteristic feature of folic acid deficiency over here. That is the correct answer over here. Next question. 12-year-old boy presents with episodes of bleeding into the joint. So bleeding into the joints is seen. There is no history of mucocutaneous bleeding over here. There is no history of mucocutaneous bleeding. Family history reveals similar illness in the maternal male relatives. Laboratory investigation shows the following: platelet count is normal, bleeding time is normal, APTT is prolonged. PT is normal, ristocetin induced platelet aggregation is abnormal. Factor 8 is said to be decreased by 50%. What is the most likely diagnosis? So this is the case where there is APTT is prolonged and there is factor 8 level is decreased. So this can happen in two conditions. Hemophilia itself, most common one, hemophilia. or von Willebrand disease. Von Willebrand disease can have increased bleeding manifestation, and factor 8 level also may be markedly decreased because von Willebrand factor carries factor 8 in the plasma. It stabilizes the factor 8, increases, prolongs the lifespan of factor 8. Factor 8 is a very labile factor. Without von Willebrand factor, it will be quite fragile. So here, in von Willebrand disease and hemophilia, we are stuck up between two, and it is male patient. Mucocutaneous bleeding is there, and bleeding into joints. So mucocutaneous bleeding is not seen over here. It is mentioning. But bleeding into joints is seen over here. So bleeding into joints is more characteristic of of hemophilia, and mucocutaneous bleeding is relatively more common in von Willebrand disease. But now let's see ristocetin induced platelet aggregation. This is said to be abnormal in case of in this patient study. So this is the case over here. So ristocetin induced platelet aggregation is generally abnormal in case of von Willebrand disease. Ristocetin is abnormal in von Willebrand disease because what is the job of ristocetin? It causes enhanced platelet adhesion. So ristocetin mediated action, that is the phase 1 of platelet plug formation, that is enhanced over here. So in case of von Willebrand defect, what is von Willebrand? Von Willebrand factor, its primary role is to form a bridge between the platelet and the subendothelial collagen. So if that bridge is not there, von Willebrand factor is not there, so ristocetin will not have its action. In spite of adding ristocetin, there will be no effect on the aggregation. So the studies will be a failure. So aggregation studies will fail. Aggregation studies will be abnormal over here. It will not result in expected platelet aggregation in response to ristocetin. So this is more likely to be a von Willebrand disease. Factor 8 level may be decreased in both hemophilia as well as von Willebrand disease, but ristocetin induced aggregation is nothing to do with the hemophilia A. Hemophilia is purely a factor 8 coagulation factor defect, intrinsic factor defect, nothing to do with the platelet aggregation, and there is absolutely normal response to ristocetin induced aggregation in hemophilia A. So this is ruled out. Bernard-Soulier syndrome can have ristocetin abnormal aggregation assay, the same, because this in Bernard-Soulier syndrome GP1B is defective, because GP1B is the protein which causes the von Willebrand factor. The platelets get adhered to the subendothelial collagen through this GP1B on the platelet. So if the GP1B is defective, so platelets will not get adhered to the subendothelial collagen. So here aggregation also, ristocetin aggregation also will be abnormal, but here factor 8 will be normal. Factor 8 normal. So here it is abnormal, and also there is a joint bleeding, so this is also ruled out. Glanzmann thromboasthenia. So here there will be normal study to ristocetin because there is GP2B3A defect, not the GP1B defect. So this will cause abnormal response to ADP, epinephrine, collagen, but there is absolutely normal response to that of ristocetin. So this is also ruled out. So the correct answer here is von Willebrand disease, though there are very close answers: von Willebrand disease and hemophilia, a male patient, joint bleeding, but ristocetin induced platelet aggregation is the one which is differentiating them. This is clearly in the favor of von Willebrand disease. Thank you for your kind attention, and we'll continue forward.